Thanks for joining us. My name is Wendy Profit, and I'm a field marketing specialist with Axonics. I'll be moderating this webinar. We are pleased to have with us today Drs. Matthew Palmer and Hillary Frank with Oakdale ObGyn in Maple Grove, Minnesota. This evening, Drs. Palmer and Frank will be speaking about bladder dysfunction, specifically stress urinary incontinence, the common symptoms that patients experience, and available treatment options. As we get started, these slides contain important safety information for products that will be discussed. As with all medical procedures, there are some risks. Please visit the Axonics website for more information, and remember to bring all of those important questions to your appointment with your physician. Without further ado, I'd like to introduce you to Drs. Palmer and Frank.
Hey, welcome everybody. My name is Matt Palmer. I'm an OBGYN with Oakdale ObGyn. I have a specialized interest in management of urogynecological related concerns like overactive bladder and urinary leakage. And I'm happy to be able to talk with some of these things about these things with you tonight. And I'll let Dr. Frank introduce herself as well.
Hi, everyone. Thanks for joining us tonight. I'm Hillary Frank. I'm Dr. Palmer's partner in crime with all of this. Also very passionate and interested in helping patients with urinary leakage and all the things involved with that. It's a unique area of medicine where we can really help patients, and there's a lot of great options that we're excited to dive into with you. So yeah, this is a very common issue. There's something that we see many patients for with this. Overactive bladder is a common condition that affects over 50 million people. And it's not necessarily something that is just that older women will deal with, which is a common thought. It's something that women of all ages will struggle with and can definitely affect your quality of life.
So we're going to talk a little bit about a couple different types of incontinence tonight, and we'll kind of go back and forth between Dr. Frank and I, kind of going slide by slide, and then towards the end, we'll both kind of talk a little bit more specifically about some focused therapies. And one of the types of incontinence we're going to talk about is stress urinary incontinence. And it's a condition that is very common. It affects 1 in 3 women at some point in their lives. And it specifically is referring, and we'll get into it more, but the type of incontinence that is related to leakage of urine with activities, usually with exercise, cough, sneeze, lifting. And so let's just understand that condition a little bit more and how the bladder works.
So normal bladder function. So normally, obviously the main job of the bladder is just to store the urine. And then in a healthy bladder or a cooperative bladder, you are able to empty your bladder when you want to, when it's convenient for you. And in order to do that, to empty the urine, the bladder muscle will contract to let it push out that urine, and then the urethra, which is the structure where the urine comes out, will relax to allow passage of that urine.
One of the other important pieces that we're going to talk about is actually bowel function, and oftentimes, as that slide indicated earlier, women will often have bowel urge and even incontinence of stool at times in a similar mechanism related to the nerves of the pelvic floor. And we're going to kind of talk about how one of these therapies can be effective for that as well. But, just in mentioning the way that bowel normally functions, basically it's the rectum will fill, you'll get a nerve signal to your brain telling you that you need to go. And, the nerve signals then need to coordinate the relaxation of your pelvic floor muscles to allow you to have a bowel movement. And in certain conditions that signal can be dysfunctional or disrupted, leading to involuntary loss of stool at times.
This is a little overview. So it could be, you could have overactive bladder, which Dr. Palmer had talked a little bit about, where you have that sudden urge to go. You can't hold it. As soon as you have just a little bit of an inkling that you need to use the restroom, there is no waiting time. Urinary retention would be if you feel like you really need to go, but you absolutely cannot get that urine out. And this obviously can be a very frustrating thing to deal with. Fecal incontinence, where you have leakage of stool, and then stress incontinence. So we'll dive into all of these a little bit more in detail.
So what are some of the things that people describe when they have overactive bladder? It's typically the frequent and urgent need to empty your bladder. It could result in unintentional urine loss, but it also can be a frequent urge that can, be uncomfortable. So it could be urinary frequency, urinating 8 or more times in a day, urgency, feeling the sudden urge to urinate that's difficult to control, urge incontinence where you involuntarily lose urine, and then nocturia, which is a term that means you're waking up frequently at night to have to use the restroom.
So what is fecal incontinence? These do go hand in hand, and a lot of patients will have any combination of these things. So you don't have to fit perfectly one box. It can be a big mix of things, and that's where we can help you kind of delineate what would be the best thing for you. Fecal incontinence could be the urgency where you might not leak stool, but you have that sudden urge to go, where again, you can't hold it, and it's almost as like that urge is what's running your life, where you have to run to the restroom and go regardless of what you have going on. It could be very inconvenient. Fecal incontinence would be similar, except for you actually do have some passage of stool. And then passive fecal incontinence would be where you don't get any urge, no signal. You just notice without any awareness or signal that you are having some passage of stool involuntarily.
And so then talking about the other kind of incontinence that we've already mentioned, it's the stress urinary incontinence. This is related to more of a muscle pelvic floor problem and a urethral sphincter problem. And it involves leakage with coughing, sneezing, laughing, exercise, abdominal pressure. Basically, the pressure on the bladder pushes the urine towards the urethra. The urethra should be able to contract to hold urine in, and it when it's having this stress urinary incontinence dysfunction, it becomes weakened and results in leakage of urine with physical activity and abdominal pressure.
So obviously these can very much impact your quality of life. I think Dr. Palmer and I are always hearing from patients that, a lot of women know this can happen to them and they just assume this is just part of life and something that you deal with. And some people do, but it doesn't need to. And if it's something that is making it harder for you to get through that meeting or get sleep because you're up at night, or go on a road trip, or, play with your kids or exercise, this is where it definitely can impact your quality of life. It can limit your physical activity. It can be embarrassing when you're out with friends socially. It can definitely become something that is embarrassing and psychologically hard to deal with. It can definitely occur during intercourse, which is obviously not when you want to be having leakage of urine or stool. It can be very embarrassing. And so this is where there's a lot of different things that we can do to help.
And a lot of people that I talk with, say things like, well, I know this is just kind of what happens when you get older. And, I think although there is a natural trend for these symptoms to increase as people get older, and there's certain factors that can worsen your chances of having it, such as having babies and having a heavy lifting job and having a chronic cough, and there's things, but essentially this condition is not something you need to live with, is normal, something that everybody just deals with as they get older, being a woman, etc. And so we want to really kind of reiterate that although you may talk to your friends and people talk about this commonly and they have these issues, it's really a quality of life disruptor that can make things that you want to do difficult, and that's where we kind of come in to talk about what we can do to help with those symptoms.
So, like Dr. Palmer's saying, is good news. There's a lot we can do to help. I think it's the nice thing where when patients come in and we're like, look at all your options, and the light bulb kind of goes off for them. We're like, oh my gosh, I don't have to live like this. And it's a big reason why we both enjoy doing this. And so there's lots of patient care pathways that we can go over with lots of different options, and we're here to help you find one that is comfortable for you, but also helps you reach your goal for your lifestyle.
And kind of what we mean by, patient care pathway is sort of this way to kind of graphically understand where you're at with your symptoms, what the workup has been thus far, and then kind of where you could go with therapeutic options. So, kind of we use a pathway that's a little bit different than this in our office, but essentially we kind of want to talk about things like initial treatments and workup. And those initial treatments for overactive bladder You know, it could look something like bladder training exercises with pelvic floor physical therapy, lifestyle changes, sometimes prescription medications. You know, additionally, as you look across, there's conservative things that can be done with dietary changes, you know, exercises, over-the-counter medications. And as we kind of fall down into advanced therapies, and typically people, you know, will trial a med or a conservative therapy for a month or so, you know, to try to kind of get an assessment of whether or not something like that could work for them before we talk about going on to more advanced therapies. And we'll talk in more specific detail about what these advanced therapies are, but they can include something called sacral neuromodulation, which we'll talk about in detail, the percutaneous tibial nerve stimulation, and then chemodenervation or bladder Botox injections. And so some of these things apply both to overactive bladder retention and fecal incontinence, and some don't, but we'll kind of get into that a little bit more as we go here. So
I'm kind of going to brush over this because this is something that it works for a very specific subset of patients, but this can be a really good option for you if you have fecal incontinence, urinary urge incontinence, overactive bladder, and you've tried some of the more conservative stuff. It's not really getting you where you want, and you want to do something that's a more advanced therapy. But the idea of doing, you know, Botox, which is something that we can do in the office, but is a little bit more invasive, or surgical options just seems like a little too much. This is a way for us to access the nerve. So in the picture that you can see the tibial nerve, which we can access at the ankle. And that actually, we put in a little needle. It's like the size of a acupuncture needle. So very small, not really very painful. And we hook that up to a stimulator, and it can actually stimulate that nerve, and it reprograms that nerve to get the nerve pathway signals that are going to the bladder and also to the bowel to, I mean, for lack of a better term, behave the way they should be. And it works really well. It can be a little time consuming because you do 12 weekly sessions in the office for 30 minutes each session. And then after that, it's usually about once a month.
Other advanced therapy that we both utilize at times is a procedure where a small amount of Botox is injected into the bladder wall via an in-office procedure. And this is done with a process called cystoscopy, where a small scope is introduced, and then down the channel of that scope, a very small needle is introduced that allows us to kind of place this Botox medication. And essentially Botox is an interesting medication that's used for a lot of medical applications. And essentially what it's going to do is work on the muscle of the bladder. Specifically, we like to kind of talk about how that differentiates the sacral neuromodulation therapy we're talking about, which works on the nerves. The bladder muscle is basically affected by injecting Botox into it, so it's not so contractile. And basically it just kind of decreases that reflex contraction of the lining muscle of the bladder, so that it's just not as active, and decreases symptoms that way.
You can talk about this one too, since this is all in
Sure. And so then going down the chain further with advanced therapies, we think about this term sacral neuromodulation. Okay, so basically the concept is that, you know, your brain is sending a signal via your spinal nerves to the bladder and to the bowel to contract when it's not supposed to, when it's supposed to be able to hold. And it's a dysfunctional signal that results in the hypercontractility of the bladder, and it creates a sense of urge. And so, you know, we'll talk a little bit in more detail about this specifically, but there is essentially a way that nerve signal can be modulated or dampened down so that it's not so strong, so that it can decrease the urge and the urinary leakage.
And then to flip over to the other type of urinary incontinence that we had talked about at the beginning here. So this is stress urinary incontinence. So rather than, whereas up to now we've been focusing on that need to go, that urge, and I can't hold it, I have to, you know, go to the bathroom often, or my bladder's waking me up multiple times in the night to use the restroom. This is more that that stress incontinence is where it's more related to activity. And so a lot of patients will say, you know, I can hold my bladder and I can, you know, go to the bathroom when I want to, but if I jump or if I'm running around with my kids or if I go on a run or I'm exercising or lifting heavy objects, I feel leakage come out. And some people will notice it just with a little bit, with like a big cough or a sneeze, and others will notice it just from standing up or, you know, carrying something heavy. And so this can be a difficult thing, but again, there are many things that we can do to help with that. So one is pelvic floor exercises. So the whole cause of stress urinary incontinence, if you think about it, is the urethra, which is where the urine's coming out, is leaky. And so rather than being able to hold in that urine when there's that extra abdominal pressure trying to push it out, it leaks out. And so that's a lack of structure, a lack of reinforcement to hold that urine in when you want it to. So a lot of our different things that we look at to try and reverse that or solve that is looking at bulking up or building up that leaky valve. So pelvic floor exercises, which most women have heard of, is doing just that you're using the body's own muscles to really try and build up that support so that the urine can't come out. Many lifestyle things can help maintaining your weight in a normal range so you don't have that extra pressure from the abdomen pushing down on the bladder, which is very much easier said than done. Quitting smoking and controlling any chronic cough can also help. Quitting smoking helps because not having that tobacco just helps reinforce and helps with the integrity of the tissue, so it's a little bit stronger. Pelvic floor exercises or Kegel exercises, which most women have heard of, also will just help strengthen all the muscles around there that are supposed to be supporting that. You can do it by yourself or you can do it with a pelvic floor physical therapist. At Oakdale, we have two that are very well versed in helping patients with this. It's a nice option because it can be beneficial. It can definitely prevent it from getting worse, or you know, it can delay how long it takes until the symptoms get worse. And there's not really any risks involved. It's very minimally invasive. So patients like it for that.
And I was going to say too, I think we often use physical therapy as an augmentative kind of therapy where people, maybe they've had surgery or they've had a procedure, but it just kind of helps to kind of add another layer of, you know, of support for what they're trying to achieve with their goals. And so, you know, you'll probably, as you work with us through these issues, get recommended to see physical therapy, regardless of the other recommendations that we offer as well.
Yeah, so it just because if we recommend it doesn't mean we think that's the only option for you. It can,
Right.
It goes hand in hand really well with other options. So the surgical option for stress urinary incontinence is physically putting in a piece of mesh that acts as that support that is lacking. So whereas physical therapy, you're using your own muscles, this just places that mesh. It's a great option. It's resupporting the urethra. It's a quick outpatient surgery. Almost everybody goes home the same day. It's done through a little incision in the vagina, so just one tiny incision. And the best thing about it is it's the best option for being stress urinary leakage free. So I always tell patients, if you're trying to get to the point where, you know, for a long-term benefit, you want to just not have to deal with this anymore and have the best option for not leaking anymore, this is a great option. Because of that, it's considered the gold standard. The downside is it is still surgery. It's a little invasive. And if you plan on trying to get pregnant in the future, or you're not 100% sure if you're done growing your family, it's not the best option because, as you can imagine, with a baby going down the birth canal or just the weight of holding that pregnancy, it can definitely alter that surgery. So a nice in-between option between these. This is good if you are still planning on getting pregnant in the future, or if you just don't really like the idea of having mesh or going to the operating room, is Bulkamid. So this works by reinforcing that urethra and that leaky valve. This can be done in the office. We do it with cystoscopy, so similar to cystoscopy with Botox, in that we put a camera inside the bladder. And what we do is we inject around the urethra little bits of water that has some gel in it. So it's mainly water, but with a little bit of gel that helps bulk up that urethra. And that just helps close off that leaky valve. It takes about 20 to 30 minutes in the office. There's no downtime after, no restrictions after, and it does work pretty well almost immediately. The only downside to it with this is that it doesn't last forever. So after a while, that gel does start to lose its integrity. And so you do need to have it done again in about 5 to 7 years.
All right, so we're going to get into a little bit more detail on the Axonics sacroneuromodulation therapy, and kind of the specific type of therapy that we're talking about as an advanced therapy for overactive bladder, urinary retention, and fecal incontinence. So how does it work? Some of the things that we're saying are repetitive intentionally to kind of make sure that the point is driven home and then you all understand to the best of our ability what we're trying to say. But essentially, how does it work? Well, the nerve problem that we talked about, it's basically providing a gentle stimulation to the nerves that are controlling those bladder and bowel functions, and sort of disrupting or kind of scrambling or modulating that signal so it's not as strong to tell the bladder to be overactive or the bowel to be overactive. It can help restore that normal communication between the brain and the bladder that can result in an improvement of your symptoms. So, basically what we'll do with this procedure, a lot of people ask, does insurance cover it? And, one of the things that we want to do to ensure that this is good therapy for you, both from a therapeutic perspective and from a coverage perspective, is to do a trial. Okay. And so the way that we typically do the trial is we'll place a temporary lead. You can go to the next slide if you're able, Wendy. We're able to place a temporary lead in the office, just usually under local anesthetic. And then that allows us to use a little external controller that's kind of clipped to your pant line, with a, see, you can kind of see in the model's hand there, that little controller. And it'll show in more detail in the next slide. But essentially, this external test wire is placed for about a 2 to 5 day trial, where you'll be able to perceive the benefits of the therapy, with the intention of having these wires be easily removed at a follow-up office visit. And during that trial time, we're going to have you keep a log of your symptoms and the differences that you're perceiving in your symptoms compared to pre-implant or pre-wire placement, and then kind of taking a look at that objectively to see the difference that this therapy is making for you. And essentially, if it is helpful, if it is beneficial, we would then recommend that you go on to have the implant. And so recently, just in the last 2 to 3 years, the technology has advanced very significantly in this arena. Dr. Frank and I have been doing these implants, I guess, for as long as we've been in practice at Oakdale, essentially. But in the last couple of years, the battery life has dramatically improved. When I was originally implanting these types of devices, we were getting about maybe 3 to 5 years at max with the implants. And now with the new devices, the Axonics R20, which is a rechargeable device, you can see the actual battery is on the left there next to that little controller. And then the F15 shows the battery slightly larger, about the same width. But essentially you're getting, with the recharging device, you're getting, roughly 20 years of therapy with, charging roughly 2 times a year through an external charger, which is that white piece, versus the one on the right, which is a truly recharge-free device where the implant can, get around 15 years without having to be recharged. Another thing I really like about Axonics therapy specifically is the ease of use, and the controller is very simple to use. It's something that you kind of set it and forget it for the most part. You don't have to adjust it really, or manipulate it. People are like, do I have to turn this on when I feel like my bladder's overactive or something? No, that's not the intent. The intent is that you set it at a setting that's that's functional, that's working to help your symptoms, then you leave it there for the most part. There may be times where we would ask you to make adjustments depending on your symptoms, and that is really essentially what the controller allows you to do. It allows you to turn it on, turn it off, to put it into MRI compatibility mode, which is something that a lot of people also ask about. Is this something I can have if I need to have an MRI? And the answer is yes. So, it's a pretty simple device that allows, control of the stimulation essentially through the battery, and it communicates wirelessly, through a Bluetooth type connection. And I just mentioned that the implant does not need to be removed for MRI scans. So, what the data suggests, what the numbers suggest, is that people do achieve meaningful and lasting improvement of their overactive bladder, urinary urge, urinary retention, and fecal urge symptoms at a rate of about 93% for incontinence specifically, at the 2-year mark. So, the idea of repetitive meds, of repetitive therapies, really, can get diminished when, the need for that, when you have a therapy that can be as effective as this and be working, long lasting for you, for many years.
And I will just say, I've had a few patients, because some of the patient information that gets handed out shows that, and then they say, well, if it lasts for really well for 2 years, what happens for the other 13 years of my 15-year span? And what I have seen, and what I think a lot of the data is showing, is it still is lasting. It's just not at that 93%, or that might be where you have to do like a small adjustment. But for the most part, you have, a huge improvement in your incontinence for that full 15 years without having to do much work.
Yeah, and I think, also there's ongoing studies to essentially establish, truly how long the therapeutic benefit can be. Many, basically these new batteries that have been out haven't actually been in somebody for 20 years yet, but, they're just, they're tested through a cycling process in the lab, essentially to demonstrate how long they'll last, but we don't even have all the data yet, because it's an ongoing process of making sure that, how long it's going to be effective for patients. So I think we're going to go on to the next specific topic that Dr. Frank's going to take us through, which is Bulkamid.
Yep. So we'll talk a little bit about Bulkamid. It's a nice option because it's, like I said, very minimally invasive, and it does not include any mesh. So whereas some patients don't like the idea of foreign body being in there permanently, or having, mesh with some of the concerns with mesh, this is a nice alternative to that. It also is mainly water-based, and so you're not putting in some abnormal chemical or beads of something that's going to be bulking this up that your body could react to. It's very well tolerated because it's mainly water. The next slide.
Bulkamid can help provide the relief you've been longing for. The short, incision-free procedure typically takes less than 10 minutes. Involves 3 to 4 small injections of soft, water-based gel into the wall of the urethra to help prevent urine from leaking out of the bladder during day-to-day activities. It's safe, quick, and most patients can get back to your normal activities almost immediately.
So this kind of gives you some idea. So the whole idea is that the opening to the bladder is just a little too open, and you need something to help not close it off, but reinforce that mechanism that's supposed to be sealing off that urine when you're doing those activities. And so this is a nice way where we use that water-based gel to form what we call cushions that closes off that opening a little bit so that the urine can't leak out, but you still can use your own body's mechanism to urinate when you want to. And so it shouldn't cause urinary retention or a slow urine stream or difficulty emptying the bladder. That's actually a very rare complication that we don't see very often. And it's nice because it's something that we can do in the office. It doesn't take very long, and it's just restoring the anatomy for patients that is causing that unwanted leakage. So it's very safe and effective. About 92% of women say that they're cured or notice some significant improvement almost immediately after being treated with Bulkamid. It's fairly simple. It's about 3 to 4 little injections. We do numb you up and give you topical and injections to help numb everything up, so you typically don't feel us putting in these cushions. The whole thing takes about 10 to 15 minutes to do the procedure, and you are awake for it, local anesthetic, and then most patients are able to go home without any restrictions and notice a long-lasting effect for about 7 years.
Well, that brings us to the end of our webinar. I want to thank you both so very much, Drs. Palmer and Dr. Frank, for being with us this evening and offering up your time and a great education. We hope everyone found this presentation useful, and if you'd like more information or to schedule an appointment, please call the number on your screen, or the practice even has web-based scheduling. So if you prefer that option, they offer that as well. Thanks for joining us, and we'll see you next time.